Our next case is actually going to be presented by Adam Brufsky and about a patient who has metastatic triple-negative breast cancer who tests positive for a germline BRCA mutation, highlighting some of the newer data. So he'll present the case and then talk about some of this data, and we'll discuss it as a panel.
So this is a 37-year-old woman who presented with a palpable breast mass and mild back pain. Mass was poorly differentiated infiltrating ductal carcinoma. That was ER0, PR0, and HER2-0. She had a staging PET CT that showed FD-avid lesions in the bone, lung, and mediastinal nodes. Her labs were normal except for a slightly elevated alkaline phosphatase. Biopsy, one of the lung metastases showed metastatic disease. PD-1L1 was 0% by the Ventana assay, and germline testing was positive for a BRCA1 pathologic variant.
For this patient, a lot of the questions that come up about what we do next has to do with whether or not you have results from genetic testing. So one of the questions is, if you have a patient like this, do you routinely refer the patient for genetic testing up front? Does that influence your treatment choices? Do you go back over your patients who have metastatic disease who didn't have testing because it was before PARP inhibitors? Ian, what do you do in this setting?
Yeah, I think given the data with the benefits of PARP inhibitors, we are doing our best to get all of our metastatic patients tested. And that's true even if they're not, first-line patients. So, yeah, I think it's, here's a drug that has, clear benefit, relatively well tolerated, and it's important that patients know that that we know that that's an option for a given patient. So testing is really important.
And do you, Adam, do you usually send the broader panels when you send it? You don't just do BRCA1 and 2?
We send the broader panel. It's rare now we'll just do BRCA1 or 2. We usually do, I forgot which one. I don't remember off the top of my head. We have a 9-gene panel, an 11-gene panel, a 20-gene panel. It's one of those.
And of course, as studies are now trying to use PARP and see how PARP inhibitors work in patients who have other DNA repair defects that are less common, it is, I think, increasingly important to us. Evita, do you send the test out? Do you usually, I don't know how involved you are with testing for BRCA, but of course, for all of us, these are send-out tests. Is your pathology department involved in that, or does that go through the genetic counselors?
Yeah, they are a send-out test for us, and they usually there are different ways that they get requested. Sometimes through the genetic counselor, sometimes just from the patient history, and directly from the clinician.
Yeah, it's an interesting time because as we've had PARP inhibitors approved, the genetic counselors have been overwhelmed, and there have been a lot more studies looking at direct consumer testing. So the oncologist talk to the patient as opposed to the genetic counselor. Do you usually refer your patients to a genetic counselor, Ian?
We do. They're doing most of it by phone these days, but even before the COVID situation, they were moving towards that just because their volume is going up. But yeah, we still go through a genetics counselor for our patients to get tested.
Do you do also, Adam?
Yeah. Well, no, it's interesting. We do, but as you know, the genetic counselors can be somewhat overwhelmed, and I think that it's really going to be a debate. But we really try to send them to the genetic counselor and do it in that context when we can. That's the vast majority of the patients we have.